Thank you for sharing.
You forgot to mention that I've never been convicted.
Yeah, you mentioned it about five or six times. I think there's a story there. But thanks so much for sharing with us your perspective and your innovative program and direction for medical education. I think it's phenomenal, and certainly the way that you've integrated social determinants of health throughout also is laudatory. The two questions that I had, number one, what type of infrastructure do you have to, whether it's at the medical school or within the university, to sustain that type of community engagement? Because I think sort of what I got the picture of, which I don't believe is true, it's like, you're going out there knocking on doors, the medical students find a problem, you go and serve it. So I just didn't get how community was involved in this, and again, what infrastructure was involved with this. And the second thing is, you mentioned interdisciplinary interprofessional education, and the example that you gave was the physician identified a problem and got somebody else to fix it. But I wonder how, and I don't think that's what you meant, but I'm wondering how it is that you engage interprofessional education, and how working hopefully together, that's also influenced the way that they address social determinants of health in their curriculum.
It's not the physician that identifies the problem. I'm talking about when they go into the workforce. Because the patient will come into the established ways we have it set up by, all the wonderful corporate medicine we have.
It was the example of finding somebody to tutor, and I thought that was a medical student example. So
I'm sorry?
It was the example that you gave of the medical student finding that somebody needed a tutor and that they couldn't do the tutor, so
we can go
ahead.
They're in the households, go ahead.
Yes, in the household. So the identification, the team works collaboratively. We do a pre-huddle, the home visit, and a post-huddle. So that identification, for example, would come up in the home visit with a faculty, typically a medical student, a nursing student. This is in the community engaged physician, the first year, right? So 1. And then the social work student. And what would happen is in that discussion, in that assessment, some of the nursing students have specific requirements. Sometimes they go for basically the needs assessments of the household. And the same for the medical student and the social work student. And with that discussion, they identify the topic. Obviously I'm the pediatrician, so I always ask about the children and the school, and education being the leading indicator of health. So that is where that came up, and we do pipeline programs, so we like to mentor. We have a health careers workshop that Outreach coordinates. It is a big event, takes an entire year, brings in all the underserved communities. So what we're saying is that the tutoring, originally the students were wanting to tutor their own household kids, but obviously they have class and the consistency couldn't happen. And it's been a challenge. We reached out, one of our doctors who's been a leader in a pipeline, Dr. Holder, reached out to the School of Education, and initially they could only do summers. And now we got where there's not only one professor, but 2 professors with the education students, and they're actually looking at doing it longitudinally, and now there's more availability. It is not easy because obviously it's a lot of households to very few students. They use technology a lot. They use basically giving them resources in the community also that are available. So that was one simple clarification.
Lack of federally funded clinics and community clinics in Dade County, to the point where most of our patients don't have access. Most of our patients don't have access, and a lot can't even afford the co-pays for these federally funded. So we have 4 medical vans that go out in a mammogram van, and these are for our neighborhood health patients and their families.
So that's helpful. I think again, the question is, we're thinking about resources for addressing social determinants of health. Are they supported by the medical school, by the university?
I'm going to be very frank. Resources are how your leader decides to allocate them, period. So what did we decide to do? Education is our mission. Our faculty are paid as educators. You can't educate a medical student without doing clinical. There's no Medicaid expansion. We're not going to make any money going out there. But as the educators, they become the most important. So David's division, which is family and community medicine, sits there, which incorporates pediatricians, med peds, psychiatry. So within there, they are all paid as educators. At the same salary that you pay along with the whatever AAMC comes out with at 50%. However, we think that primary care is so important. We're not there to produce primary care, but we're there to say, this is so important, this is what you want to do. They have the prime location at the medical school. So they teach not only the small groups, the organ systems, the clinical skills, the neighborhood help. They're their mentors. And they're right where the OSCE rooms are and the other teaching rooms, so the students are always walking by their offices. So that exposure, because I could never understand how we could say primary care is so important, however, the neurosurgeon's making 7 figures, so he gets the big office. If I was sitting there as a student going, well, if it's that important, why does the important one get the trailer? You know, so you got to put your money where your mouth is. And so what we do is we take our educational dollars. We go out in the community. One of my jobs is to raise funds, and so that's what we do. We have a pretty nice little endowment. I got to make it bigger. But with the endowment is what we use to pay things like our community outreach workers, because they're not paid by the state. And if they're an integral part of what we do, it's my job to protect them and make sure they're there. Because as they leave, we're going to take other people from the community and employ them. That's how we can stay in perpetuity. We're not, now, do we take grants and things like that? Anybody here offering grants? Yes, hell yes. Okay, and give me time, we can write some, okay? But in the meantime, that would be supplementing to our core responsibility of taking care of that. We're a public university. It comes from the president of the university, the board of trustees, to the dean on down, and that's what we do. And so.
I just want to say that the expense is not insignificant, and the investment is not insignificant. We have 18 physician faculties in the budget who are, you know, dedicated to teaching the medical students and to doing home visits. The infrastructure, the community organizations have been educated about our program, and so as they identify people that have particular needs, social and medical, they refer them to us. Our outreach workers go out, do an initial assessment. We're sending students into households, so we have them doing a safety assessment. We have 3 police officers now who are on our team, so that the students, when they're out in the field, are in communication with the police officer. We go and...
Which, by the way, we're in the highest crime areas of Dade County. So, I mean, we're in the areas where it's not unusual to have 4 or 5 killings in a week.
But we're integrated so that we're teaching the same faculty are teaching in basic science courses, in clinical skills courses, in the clerkship, in the home visits.
Pay for social work?
We pay the medical school supports social work faculty, supports law faculty.
And we're supporting nursing faculty.
And nursing faculty. It's a...
Money talks.
It is the signature program of the school. It's what the school has invested in order to be able to provide students an opportunity to engage in, as we said, in the natural environment, to see people in their homes and to understand the impacts of social issues and health issues in their home environment.
And the only time our safety officers go into the home is if somebody is identified with a legal handgun. Our safety officer goes in there, and then we train the entire family in gun safety, and our department pays for the lock. Now, we're doing more for gun safety, which gun violence is a major social determinant of health. So we'd like to get rid of all of them, but it's legal in the state of Florida, and a lot of them have it there for safety. And one of the testimonials from one of the families speaking to the students was, I had to quit my job because my father became demented. I was 65 years old. I couldn't afford to go to work and pay for somebody to care for him. Because of the neighborhood I've lived in, and I've lived in that house my whole life, and the crime got so bad I bought myself a gun. I didn't invite my grandchildren over because I was afraid they'd find it. And it wasn't until that the lock and the training was done that I now feel comfortable with my grandchildren visiting their great-grandfather. So, I mean, these little things add to what we refer to as the quality of health. Health is just not the disease. I tell the students, I'm a gastroenterologist. You have a normal colonoscopy, your liver is normal, your EKG is fine, your stress test is okay, your chest x-ray looks good, your comprehensive metabolic panel is perfect, your blood pressure, your physical exam's normal. You get home, your house is in foreclosure, one of your kids has a behavioral disorder, and your spouse just left you, how healthy do you feel? By our parameters and our list, you should be very healthy. But the reality is that all these things exist in people's lives. And we become the focal point as physicians because the way our society and the world is that people come to see us. But we need to start looking in the direction that our patients are looking, not in the direction we're looking back. And learn
Great.
from them.
Let's, we have a couple questions from the committee, Bianca, and then we'll go ahead and get you, Ruth.
Sure. So thank you for this great presentation. I think what's exciting is that you're really getting to start anew and fresh and think about how medical education should look. I share a lot of your same viewpoints. So I had the joy of hearing a little bit about the aftermath of thinking about curriculum renewal at a major medical institution. And family medicine is in the department in which I reside. I'm not a medical doctor myself, but I heard that there were challenges in just trying to get anything around primary care in the overall curriculum. What are some advice that you would give to some of the major medical institutions in trying to integrate some of the courses that you're talking about, and who really helps to lead some of that conversation?
Well, I have two aspects of myself, the Cuban and the Irish. The Irish answer would be just blow it up. Okay. However, that's not acceptable. What I think where you really need direction is you need direction from your leadership. You need your dean to be supported by your president and saying these are the changes, and then you got to work your politics. Like I said, some of the most difficult things at the beginning was working within the institution of medicine, because we're very comfortable when we do very well. So the other thing we need to do in this country, and we're doing slowly, is we need to change the vending machine. Doctors, like anybody else in this country, will respond to how they're paid. You know, I mean, try and figure it out. Since when did you really have to be that smart to be a dermatologist? When they opened up the spas and you could make $1 million a year. And I'm kidding, you have to be smart to be a dermatologist. Not that smart, but smart. But I mean,
Okay,
so it's leadership issues, yeah.
okay. I'm a nurse midwife and anthropologist. I'm credited with having started the first freestanding birth center in the country. Now there are about 300 of them. But I want to congratulate you on breaking into this situation that we have with families in our country. But I want to remind you that the best place to break in is in the maternity cycle, because then you have access to the family, you have access when they're eager to learn about the care of the child and so forth. So it just makes me feel, I have great respect for where you break in, but why not break in earlier? Why not start in the pregnancy? Why not start with the mother? And I think that I'm running an agency here in this town, came here to show that the kind of care that midwives can provide, because the midwife model is different than the medical model. They should be complementary, but there is a difference. We have worked in a low-income area of the district. We have demonstrated that we can reduce preterm birth by 2/3, low birth weight by 3/4, and cesarean section by 2/3. Now, that saves a lot of money, and the Urban Institute has studied us. The Urban Institute, if you read this last study they reported on our costs, which appeared in Medicare and Medicaid Research Review earlier this year, what that has shown is that if all Medicaid births in this country were managed on our model, it could save $2 billion a year, and yet have these better outcomes that I just spoke about. So who's going to get that $2 billion in savings if it ever comes out to that? You know, that's another thing. The politics of it is so distressing to me. You know, that the way the Medicaid managed care companies pay, and when Medicaid managed care came to us, you know, they said, well, what do you charge? And we told them what we charge, which is what we thought it really cost, because we're doing an innovative demonstration, and we would like other people to pick it up. Well, they said, we'll give you half. Never asked us for our financials, nothing. Now, the fellow who ran that particular Medicaid managed care company is in jail, but I agree that we need to work together, and we need to look carefully at where the right place to break in. I think breaking in where you break in is wonderful, but I think that you can break in the maternity cycle and save those kids who are getting born a lot of the problems that the kids you see who are now grown or in college might have. So I'm 88 years old. I'm going to go home.
So thank you. Excuse me. Excuse me if I can interrupt. Thank you, Ruth, for your comments. I want to make sure we get one more comment in before the break. I think your comments again help us as a committee think again about where it is we need to start and intervening in those social determinants. So thank you.
I agree with you, but I think what we need to look at is a menu of places to intervene in, not just one. There are multiple issues. So. But I thank you for your comments and thank you for what you've done.
I want you to know that I have the best one.
And then, do you think you would like Florida?
And congratulations on
Listen,
that first birthing center.
That's right. And you're lucky. Your Medicaid guy went to jail. Our governor just got a big Medicare fraud bill of and ended up becoming our governor. So anyways.
Because I think that this is the best place to break in the maternity cycle.
I got you.
And although I'm 88, I think maybe I'll get pregnant tonight.
Wow. Wow. So I don't know how you top that, but
Okay.
one question and one brief comment because you're
That's it.
standing
You got it.
between
Go
us
ahead.
and break, okay?
Sorry.
I'm Miguel Paniagua. I am a forum representative representing the National Board of Medical Examiners, so congratulations on your USMLE pass rates.
Well, thank you.
Straight from the source. I'm also proud Bolivian Irish myself, so.
Join our club.
My question is, what kind of outcomes have you had in terms of affecting people's specialty choices coming out of your first class? And what expectations do you have going forward in terms of perhaps expanding the primary care workforce, especially in Florida?
There's a couple things. Remember, our first two cohorts we graduated about 35 students. I think we were averaging about 40% going into primary care, but there's a caveat to that. You know, you go into pediatrics, you go into medicine, you can specialize. I think that as the one of the things that we did not take into account as a brand new medical school with a brand new curriculum was a thing called social media. So our students were all freaked out. Everybody else is doing it differently. We'll never pass our boards. We'll never do this, et cetera, et cetera, et cetera. As the years have gone on, we have more students with graduate degrees in public health and things of that nature that are more interested in going into primary care. I think our cohort last year was 42%, something like that, or
Johnson was over 50.
over 50% went into primary care residencies. Our very first graduating class is just now finishing the third year of their residency. So those that went into primary care, we don't know what they're going to do after that. But I think that is going to change for a couple of reasons. The number one is because of the way we have it set up and what I call pre-admissions. In other words, medical students talking on social media with pre-med students and the excitement of what they're doing and what's going on in there. I think the other thing that's going to change it too is the vending machine and being paid for your outcomes. I don't know why everybody is so afraid of being paid for performance in medicine. If we're that competitive, then be competitive. So, but that's the way. Thank you.
Great. Let's thank our panel and for a lively discussion.